Víctor Hugo Borja Borto. Bien, pues muy buenas tardes con todos y todos. Iniciamos con la.
Good evening, everyone. Let's begin with the daily technical report. As we look at the international data, we see a decrease in the amount of confirmed cases globally. Now we are at 59.3%. And this is, of course, because the European region, the European continent, has been showing a decrease, a downward trend that we've been observing during the past 4 days. And the average fatality rate is 6.3. Now, here we can look at the comparison between regions and how the European region is showing a decrease and the Americas are showing an increase. Now they are represented in a 44% of the overall registered cases during the past 14 days. As we have been saying, there will be a time in which these two bars will invert their relation, and the Americas will be the region with the highest representation in the chart. Here we can take a look at the national data. We have, to this day, 5,399 cases. We have more than 10,000 suspect cases and almost 24,000 negative cases. Unfortunately, the death toll is 406 deaths so far. And as we can see, the different colors represent the highest concentration of confirmed cases per state. So light green being the less amount of cases, the lowest number, and orange towards reddish or even brown, that is the highest concentration of infected cases per state. Now, if we look at the following slide, we look at this same distribution, but this is the bar graph representation. So this is the total number of cases per state. And the colors are the same colors that are represented in the map. Next slide. This is a different map. This is a new map that integrates the accumulated incidence rate per 100,000 inhabitants. So here we can actually take a look at a comparison between the population within each state and the number of cases. And here we can say that the states that appear represented in darker green have a higher population, or they're being more affected by this the contagion of this disease, but taking into account the population ratio. So this is what we call the accumulated incidence rate. And we can take a look how the southwest, the southeast state, southeast region states, Quintana Roo, Campeche, and Yucatan, as well as the northern states like Baja California and Baja California Sur, they are being more affected than other states, and of course the Mexico Valley area is also being affected greatly. Here we can take a look at that same incidence rate, but represented in a bar graph. And the average incidence rate of the whole country is 4.22 cases per 100,000 inhabitants. Here we can take a look at the age group distribution, but also taking into account the proportion between inpatients and outpatients. As you know, the yellow bars are those patients who required hospital care and had to be hospitalized at some point. The green bars are those patients that only required external consultation, and they were able to have a normal recovery process in their houses or outside of the hospital. And we can see the same trend that we have been observing that the highest the age group, the older the citizen, the higher the probability of being hospitalized. We also have the sex distribution. Males are overrepresented since they have over 50% of the cases are male and the remaining percentage is female. Here we can have take a look at the clinical state of these patients. These are confirmed cases that have tested positive for COVID-19. So we have 65% of outpatients, we have almost 11% hospitalized stable, almost 20% of hospitalized patients that are in severe conditions, and 4.4% have had to be intubated, which means they are a critical state. This is 237 that are in this situation. Now let's take a look at this chart that we started showing yesterday. We have a column for confirmed cases and we have the same distribution, which is the over 5,000 cases that have been confirmed so far, but they are presented taking into account the distribution of the suspect cases as well. And these suspect cases are also in different clinical states. Of course, most of them are outpatients, meaning mild cases with mild symptoms, but we also have, out of the suspect cases, we also have hospitalized patients that are in stable condition, we have hospitalized cases that are in severe condition, and hospitalized cases to a minor extent that are in critical condition. We have 90 deaths that are currently suspect, and once we get the results of the test, we will know if they will fall into the category of COVID-19 related deaths or they die because of other causes. Here we can take a look at the distribution of these fatalities represented, taking as reference the time of death, the date of the death. We can see a curve, which is the line in black, that graphs the accumulated data of how these fatalities have been presenting themselves. Basically, what we want to see is what is the trend that we are observing in regards to the fatalities by COVID-19. And here it is represented by date, meaning each date with how many fatalities we had reported. So when we see that the curve is not going up anymore, means that these last few days we haven't had that many deaths confirmed so far. But let's remember that we still have an amount of deaths that are suspect, and they could enter into the category of COVID-19 related deaths as soon as the test results come out. Here we have the comorbidity information, and we can take a look at how when talking about the fatalities, the sex proportion is a little bit more marked, because we have 70% male and 30% female, and the three highest comorbidity factors, risk factors, are hypertension, diabetes, and obesity. And there's also another conditions like smoking, cardiovascular disease, kidney failure, immunosuppression. So please remember, all of those people who have any of these diseases or are over 60 years old, they are the most vulnerable groups right now, including pregnant women. And those are the groups that have to be taken care of the most by relatives, by friends, by neighbors, to prevent them from getting sick. Here we can take a look at the distribution of these fatalities, and basically what appears represented in the blue bars is the number of fatalities per state, but we also have on the green line we have the fatality rate per state. And our fatality rate goes from 23.9% to a very small percentage in other states. And this is the mortality rate information, which, as you remember, this is related to the population. While the fatality rate is related to the amount of confirmed cases, the mortality rate is related to the population of each state. And we also have some important variation across states. Here we can take a look at the distribution per age group that we have been talking about. Before 25, the fatality rate is the lowest, is 0.3. Actually, yesterday we didn't have any deaths that belong to the under 25 age group. Now we have one unfortunate death that also had a comorbidity high risk factor, which they had a cardiovascular condition. Then we have the age group that goes from 25 to 59, and that is the group with the highest number of deaths, but not the highest fatality rate. The fatality rate is 5.6. And now we can take a look at the over 60 age group. The fatality rate has increased. Now is over 17%. So all of those senior citizens out there, please do take care of yourselves. Here we have the positivity rate information. Here we're including week 16. On the data we presented yesterday, we were presenting up to weeks 15. Now we're including week 16. We can see how the positivity rate is now went from 19.27 to 14.55. So it's decreased slightly, but we know the variation can continue during the upcoming weeks. The positivity rate for influenza is continuing to decrease, so we know COVID-19 is basically replacing influenza when it comes to confirmed infectious respiratory diseases. Here we have the information regarding the cases that have fortunately and happily recovered. We have to this date 2,125 recovered patients, which is 39% of the overall cases. And we can see how as the epidemic moves forward and we continue to see an increase in the number of infected cases, we will also see an increase in the number of recovered patients. Here we have the curve for the suspect cases. So there is variation every day, and every day we have newly confirmed suspect cases that could be of respiratory infectious diseases that could be caused by COVID-19, but not necessarily, and they are cataloged as suspect until we have test results. Remember, the relation is we have thousands of people who have ended up being negative, and they are not COVID-19 cases. And finally, we have the epidemic curve that ends at the current day, in which we have 5,399 cases, and we also have the little yellow bars that show the amount of newly confirmed cases per day. We can see how we are experiencing a somewhat stable trend during the past 5-6 days, which means we are not observing quite yet a turning point or an increase in this tendency, but this is something that we will continue to monitor, because it is always a possibility that we see an unexpected increase, and then we have to act accordingly. Thank you. That would be all. Thank you, Doctor. It's 7:15. It's 7:15. Let's begin with the Q&A period. Yes, let's begin with you. Because yesterday you wanted to ask a question. Thank you. Good evening. Doctor, I have two questions. One of them is for Dr. Alomia. In a radio show 2 weeks ago, there was an expert that was giving their opinion, and they were being asked if the speed of the transmission rate has to do with the fact that some people are not taking these safe distance measures seriously, or is it the natural development of a pandemic such as this one? And a second question for Dr. Gattel, what do you think will happen with the studies that we have so far? What will happen first? We will be able to have a vaccine or a treatment? Definitely, yes. And this is very easy to explain. We know this disease is transmitted from one person to another person, from an infected patient to a healthy person, by coughing, by sneezing, by projecting saliva drops. The virus can be transmitted to another person. If this person who coughs or sneezes comes across another person who is susceptible to this disease, that in this situation is all of us who haven't gotten sick, we are all susceptible to this disease because none of us have any antibodies that can protect us against this disease, and there is no vaccine so far, so none of us are vaccinated, so we are all susceptible to getting infected with this disease. So if an infected person comes across with a healthy person then and sneezes or coughs, then they can transmit the virus to this person. If the safe distancing measures are not implemented, if people are still interacting with each other in enclosed spaces or to very close distances and participating in gatherings with a lot of people, of course we will have a faster rhythm of transmission, a higher rate of transmission, and a higher number of infected cases, and eventually a higher number of deaths. That is why it's very important to respect and abide by the measures of safe distance and social distancing that we've been implementing, because this is a measure that massively can mitigate the effects of the pandemic and slow down the rhythm of transmission. Now, the accumulated incidence is a statistic that is calculated taking into account a population basis, in this case 100,000 inhabitants, and to see how many patients are being infected per day compared to this population. If the accumulated incidence rate is stable, this means that less people are getting infected every day, and that would be a good thing. And as to your second question, in general, the development of new pharmaceutical products, be this vaccines or drugs or medication of any sort, usually takes a certain period of time because there are certain concerns that have to be resolved first and certain trials that have to be carried out, especially regarding biosecurity. And there is a cycle that is very well known in which the active principles of a new drug or a new vaccine have to be tested first in experimental conditions, literally with not living conditions, which means in vitro conditions. Then we can experiment with animals or other species. This is all the preclinic stage of the experimentation. And after that, and if the case requires it, we can use bigger animal species. Then we have a clinical investigation phase in which we have a very, very reduced number of people who participate in these studies, and then we can evaluate the safety of using this product. Then we can move to another phase in which we can do the same tests with higher numbers of people, sometimes tens, sometimes hundreds, to continue evaluating the efficacy and the security of using these drugs. Then we have controlled studies, which is a third stage in which we have thousands or tens of thousands of people involved. Then these studies approximate in a close manner real conditions of the world. And then we have another implementation period in which we can evaluate it. We're using it in larger populations, like millions of people. So it's a very long, very complicated, very detailed process, but it's roughly what I've explained is the cycle of investigation for pharmaceutical products, including vaccines. And how long are we talking about? In the best scenario, 2 years to 3 years. Every time we have an emergent disease or an epidemic, we try to accelerate this process, but it's never been reduced or accelerated beyond the limits of 2 years. Minimum amounts of time we need is 2 years so far. So what other options that are being explored is using drugs that exist, that have been used for other diseases, and they could be used for COVID. And those, if those results come out and it turns out we can use them, that might happen a little bit sooner. There's several medical professionals that are being hired as in semi with work contracts that are not like full contracts, that are like half-time sort of contracts. They have less salary, they have less benefits, they don't have a certain security. So how can we address the work situation of these medical personnel? Are they being abandoned? And talking about the management of dead bodies by COVID, it's been said that the way to dispose of the dead bodies by COVID-19 is cremation. So some people have expressed their concern about cremating cadavers without first recognizing them. So how can we identify these people before cremating them? Thank you for the questions. Dr. Borja, can you answer to the first question about the work status of the doctors of IMSS? In the IMSS case, all of the doctors, nurses, and personnel that is being hired for the following 3 months of this epidemic, and overall for an overall period of 6 months, to cover all of the duration of the epidemic, they are being hired on a basis that we call by specific work. This gives them full benefits, and they have social security and they have salaries, so they are not hired under the conditions you just implied. So that's the information I have, like so far regarding the hiring conditions in IMSS, and in the state systems of health. There are close to 98,000 workers, doctors, nurses, chemists, psychologists, who are hired under the conditions that you are talking about, that are non-ideal because they don't have benefits. They don't have full benefits. Sometimes they have partially some of the benefits. They have irregular salaries. We have detected that since 2019. We have been talking about this as one of the problems that needed to be addressed and why we created INSABI. And it is one of the 4 missions of INSABI to solve the working conditions of these working conditions that are subpar of these medical professionals in different states in the country. This is a plan that we had since before COVID-19. The plan is still on. We didn't anticipate that because of COVID this process could be accelerated, but we're definitely committed to the fulfillment of this purpose. Not only because in this way we can have a more robust, more stable health system, but because it is a universal and fundamental element of social justice and work justice. And talking about your second question, which I also appreciate, we did publicly presented the first set of guidelines regarding the handling of dead bodies, and this was to be implemented during phase 1 and 2. Actually, because we published it recently, it wasn't implemented during phase 1, and it's just being implemented during phase 2. This concern regarding the cremation of dead bodies in a country in which we have an awful problem of forced disappearings. Of course, there is a law that prohibits cremation from happening within unidentified bodies, because we need to have the possibility of looking and searching for the disappeared people. As you know, we have a national commission for the search of people who disappear, and cremation could interfere with this process. We are discussing this topic in great detail with the Ministry of the Interior, in an environment of close cooperation, and we are very close to presenting a full cooperation agreement that presents the specific guidelines for the handlement of these unfortunate losses. And so far we have identified that it is not viable to consider cremation, even though it is recommended from a health perspective, but because of the conditions of our country, cremation is not a suitable option. And of course, originally we had thought about cremation because dead bodies could be a source of disease, but yes, after all of the discussion we've engaged in and attending to the dispositions of the law of victims, of the national law of victims of Mexico, we will be eliminating the requirement for cremating the dead bodies. All right. Doctor, you've talked about how the economy is important and plays a major role in this strategy that the Ministry of Health is implementing. But what about the beer industry? The beer industry is one of the biggest industries in Mexico, and you have said that it's not a non-essential. It's a non-essential sector of the activity, but here in Mexico we have thousands of little stores that selling beer is 40% of their income, and we have sectors that are being affected by the stopping of the operations of the big beer producers. I know beer is not a first necessity product, but the beer industry is an agro-industrial product that has a major role in our economy. So my question is, don't you think you are affecting the state of this beer industry? Is this really necessary? Maybe have you considered having more clearer, more specific information regarding why you made this decision of stopping the activities of the beer industry? Maybe to explain this to the people who have little shops. Also, why is it considered high-risk conditions for workers to continue to work at beer factories? Thank you for your question. I don't doubt that there are people who are owners or workers in different stores that commercialize and sell beer that may have this concern, but I know that the big capitalists, the owners of the actual big beer companies, they were the ones who first expressed this concern, and they basically said everything you just said. It was literally what they said, what the big capitalists that own the big beer in this country, they basically said everything you just said within the first few hours of us publishing the guidelines that required for the big beer industries to stop. It wasn't the little producers, it wasn't the little shopkeepers who expressed this concern. It was the big capitalists that expressed these concerns that you are expressing. Now, the logic or the mechanism that are inherent to these massive health measures is the main purpose is to decrease to the best of our capabilities the number of infected patients to the end that when we reach phase 3, which is going to be very soon, we don't have a saturation of our medical infrastructure and the medical facilities because the lives of of many people depend on this, on their having sufficient amount of beds, sufficient amount of human resources, and of ventilators. So all economic, legal activities play a role within our country, of course. So we have received an extensive collection of petitions, of letters that are all very respectable, all very polite, and of course that are a result of the right to petition that we have in this country. But basically they all have the same argument. Each industry identifies their own economic sector, in this case industrial, in other cases commercial, in other cases the services sector, as essential. But the criteria has been meticulously studied. We took as reference some of the guidelines regarding essential economic activities that exist around the world to contrast them to some of the guidelines that had been developed in Mexico by the Ministry of Economy. So we did a joint study and that involved the Ministry of Work, the Ministry of Health, the Ministry of Economy. It was a joint work by many institutions. And we reached the conclusion that there are some activities that are essential and some of them are non-essential. And of course, the people who belong to those non-essential activities will not be completely satisfied with the fact that they have to stop. And this is understandable. There was a press release that authorized the selling of beer supplies of the grain that is used to make beer, because the suppliers didn't have the capacities to store it. So we authorized the selling of those materials in order for them to be able to store them, but that was it. We didn't authorize the production or the distribution of beer. We made the official release March the 31st, and it's very clear which activities belong to the essential sectors and which activities belong to the non-essential sectors. And all of those who belong to the non-essential sectors must stop and are not authorized to continue operation until this whole situation is over. Today there was a virtual meeting with the state secretaries. What were the agreements that were reached regarding the hospital reconversion plan? And also the supplies that are still lacking in several hospitals across the country. And also, apparently, you've said that there's been a decrease in mobility of 70% in Mexico City, but this hasn't happened in other areas of the country. So what can you say about this? Also, regarding phase 3, is there a possibility that not all of the country enters phase 3 at the same time? Or will it be at the same time? Yes, today, this morning, we had a virtual meeting with different secretaries, the health secretaries of each state. And I was representing Dr. Alcocer, who is the National Secretary of Health. He was in a different meeting that was also related to the same topic, but with other people. And we identified an attitude that is a very positive and very professional attitude that coming from all of the different state health secretaries. They have shown great commitment and great dedication to identifying the different challenges and opportunities regarding the overall strategy. They also expressed their concerns. We have some reconversion processes that are still haven't been completed so far. Their completion depends of whether some hospitals can start liberating some beds or not. Obviously, these people who are using these beds cannot be thrown out of the hospitals if they haven't completed their treatment. So we have to wait a little bit for that. But what we can address sooner is the rescheduling of certain procedures and certain surgeries that do not that can be postponed without that representing a risk to the patients. There are many surgeries and procedures that can be postponed, and we are currently reorganizing the schedules in order to postpone those surgeries and have more space in those facilities for the treatment of patients during phase 3. Also, regarding the supplies you were talking about, we were asking the 32 states health secretaries of whether the different hospitals had received the supplies and they were already using them. Most of them said yes. Some said some hospitals were still waiting for the supplies because they were stuck at some point during the distribution chain. Some of the secretaries actually talked about how they're still lacking some supplies. We told them, like, well, we are still having some shipments that are coming from China. We've had 2 shipments so far, and the following shipments will be completed during the following days. And talking about the hospital conversion program, we have a digital platform that the government has developed during the past 10 days in order to better coordinate this reconversion program. And through this platform, all of the different institutions nationally and the different institutions at the state level can all input their information and their data, so we can have a centralized database and we can be in better coordination with everyone. So it was a technical conversation regarding this preparation process for phase 3. Now, the other question is very interesting, of whether we can regionalize or not entering phase 3. I would like to remind you of the first stages in January, in which we had a chart which had 3 colors, green, yellow, and orange, that represented the 3 phases and the different control measures that were relevant to each phase. In that moment, we identified the phase 3 with the possibility of it being regionalized. And technically, it could be regionalized because there are areas within the Mexico Valley region that could correspond to a phase 3 currently. But we have considered that this could bring some confusion to the population. It could be not that clear because in the end, the measures are also related to neighboring states. Sometimes, in some situations, the mobility between states is very important. There are some cities that are indistinguishable one from the other, one state from the other, and if we had this selective process of regionalizing entering phase 3, this could be confusing for the population. But we are actually considering just having a national level phase 3.
Gracias, secretario. Carolina Rivera de Milenio. Usted acaba de hablar del tema de los insumos. Dice que ya se
Yes, you just talk about the supplies. You said the supplies that have been brought to Mexico so far have been distributed throughout the 32 states, but there are states that are still saying that they have they haven't received the supplies, that they don't have masks, or the supplies that in theory have been all distributed and delivered. Do you have the detail of which supplies have been delivered to which clinics and which are in this transference process? And also I would like to ask you, what supplies are coming on the following 9 flights that we are waiting for? And are you planning to make more purchases? Yes, all of the flights that are necessary. We will continue to purchase all of the supplies that are necessary to deal with this crisis. The aircrafts are only the transportation means, but it's not a fixed number of purchases that we have established. When you're talking about which states, my answer is 32 states. All of them have received the supplies, and we have the certifications, and we have the documents that state that they have received the supplies. Remember, once the supplies get to the state authority, there is a number of steps that have to be completed within the state before these supplies reach the hospitals, and these steps are the responsibility of the state authorities. So I would like to actually make a petition to you. If you know of any specific cases of hospitals that haven't received their supplies, and I'm addressing all of those nurses and doctors and health sector personnel. If you're a health worker and you're working at a clinic and you're identifying that you don't have enough supplies or resources, first of all, investigate what's happening within your medical unit. Number 2, make sure that your expectation regarding the supplies corresponds with the technical guide of control for infectious disease. This is very important. We have explained this several times. I explained this morning. There was a misuse, there was a waste of certain supplies that are very important, like the N95 masks. Why? Because because the expectations of some individuals, not all of them, but a big number, was, I need an N95 mask to feel protected. But there are technical guidelines that are very clear that specify that the N95 mask must be used only by those who are directly treating those patients and in direct contact with the respiratory secretions of the patients. For example, the nurse who measures the blood pressure of those patients do not need a N95 mask. The door guard doesn't need an N95 mask, right? So what happened 4 weeks ago, roughly, is that all of these supplies were overused by personnel that didn't need them, and that led to scarcity of these supplies. Now we have supplies again, and the supplies are at the states. So all of you and all of the citizens, and especially those health workers out there, make sure that your expectation for the equipment you feel you need corresponds with the technical guidelines of for the control of infectious disease. If it is the case that you need these materials and you don't have them, please announce it, because we know by experience that at this very state level, last stage of the distribution chain, there can be things that stop those supplies from getting to the final destination. So we will address these problems, but we need you to denounce them. Also, let me make a clarification. I never said that only Mexico City has decreased mobility. I said that only Mexico Valley area has direct documented evidence of the decrease. It is very possible that in other regions of the country there has been a decrease in mobility, but we don't have the means to measure it in the way we have in the Mexico City Valley area. And the upcoming shipments, the flights that haven't arrived yet, they have equipment for even for ventilators, for the maintenance of ventilators. They also come with masks, gloves, and different protection. All the protection equipment we need will be arriving in the upcoming flights. Good evening. Doctor, during the daily conferences you've been presenting, we have gotten to know the scientific evidence of epidemiologists that tell us why, that tell us the reason for these isolation measures, for this quarantine, for all of this. But I would also like to know, when can we know the evidence, the scientific evidence of the economists, of the sociologists that tell us the pros and the cons of these isolation measures? Thank you. Very important question. In general terms, these measures, these kind of measures, we want to reserve them, and this is the case of Mexico. This was a state decision. We want to reserve them for the moment that they cannot be do without. Remember that in January and February, there were opinions appearing in certain media, in certain journals, and certain people out there that were demanding that Mexico adopted measures like the ones like the measures that were being adopted in other countries at those early stages, like Italy, Spain, and even the United States. And repeatedly we said once and again, there are two important reasons not to adopt those measures yet. First of all, some of these measures are not based on technical information and on scientific evidence. Specifically, we're talking about the closing of the airlines and of different flights, because throughout all of history, and the closing of the borders, because throughout all of history we have not found any scientific or historical evidence that supports that closing your borders will be effective in dealing with the pandemic. And the other reason was, we said there are certain measures that the government will adopt in due time, but not yet, because Mexico entered the pandemic 1 month after Italy or Spain, for example. Also, we said that these measures have limits because they have negative consequences. They have a negative impact on the economy and on the society. And we emphasized that one of the biggest concerns was that the overall country economy would be impacted, negatively impacted, but also the family economy of each family, because Mexico has an extremely unequal distribution of wealth. There is an enormous social and economic injustice in Mexico that we've had for over 40 years, and it's been getting worse every year, to the extent that half of the Mexican population lives in poverty and 12% of the population lives in extreme poverty. And what this means is, all of these people we're talking about that live in poverty, they eat with what they earn every day. So we executed the measure at the moment that they needed to be executed, and not before, and not after. One of the turning points was Friday, March the 13th, because we had an inflection point we had an increase in the amount of newly confirmed cases every day. Also, we took into account that these measures could extend over time to 1 month, 1 month and a half, even 2 or 3 months, if it was necessary. And coming back to your question, yes, we have been in close cooperation with experts from other instances, such as the Ministry of Economics, of the Economy, of the Ministry of Work, of the Bureau of the Treasury and Tax Collection, and we will continue to have meetings with them, and we will be presenting information on that regard to you. Yes. The last few days we've been very concerned, and we've been working hard to source all the ventilators that we will need and other supplies that we will need. And we have also received donations. But there is a kind of help that I would like to ask of you, of the citizens. Help us to avoid these patients from getting to the hospitals. The best way you as a civil society can help us to deal with this pandemic and deal with the phase 3 is isolation and is social distancing. I know it is very concerning to see a patient who cannot breathe and they could need a ventilator when the pandemic reaches its peak. But the best way to help is to decrease the transmission rate, to decrease the contagion. We still have some time to have a positive effect on the numbers that we'll be seeing during phase 3. And the measures that have been adopted by the government are precisely thinking of what's going to happen during phase 3, because this epidemic is not dealt with through hospitals or through ventilators. It has to be dealt with through the support of all the population, through washing our hands, through keeping our safe distance, through avoiding contagion risk, epidemiological vigilance that is being carried out in the country through the study of cases, through the timely detection of cases. All of these measures come into play. Yes, the hospitals, the preparation that we are doing in hospitals is part of it, but they are not the only part of the equation. So, yes, if we all do our fair share and we all collaborate, yes, we will have equipped hospitals and we will have increased capability in the health sector, but we still need to prepare ourselves to the reality that we will be seeing hospitals that are full. So if you want to help us, if you want to help the hospitals and the health sector be as effective as it can, you still have the opportunity of helping through staying at home, keeping your distance, decreasing the risk of contagion. We have 2 minutes left. Let's see if we have enough time to answer one more question. Thank you. Since we are moving towards phase 3, as you have repeatedly said during the press conferences, so what is the current state of occupation, so to speak, of hospitals currently? 30%, 40%, so we can get an idea of what we're dealing with. Because we know in the whole Latin American region and the Americas, we are still moving towards the most intense stage of the epidemic. And also, Dr. Borja, we've heard testimonies of people who are relatives of patients that have been hospitalized, and they're still not receiving timely information and clear information regarding the status of their relatives. So, what's going to happen there? What's happening with doctors in this regard? Thank you for the question. Yes, talking about the timely information. This is very important, that all doctors are aware of who are potential patients and isolate them in that moment. We have known of cases of patients who go first to a pharmacy, then they go to a private doctor, and then they go to a public hospital. And when they reach the public hospital, they are in severe condition. So please, all of the doctors in the country, we have to be aware of the symptoms. We have to be aware of providing the proper diagnosis. And also, remember, if we have shortness of breath, all of you remember, if you have shortness of breath that is an alarm sign. That means that you have to go straight into the hospital. Unfortunately, all of the deaths that have happened are very sad because these are patients that are unaccompanied. They are not in the presence of their relatives or their friends. They die in the presence of doctors, of nurses, but they are not in the presence of their relatives, and this is a very unfortunate situation. So remember, we don't have a specific treatment, so we have to find a way for them to be communicated with the relatives. Even though the deaths usually occur in moments in which they are intubated, they are sedated, they are basically asleep. But still. Thank you for the question. I would simply like to add, as the days move forward, it is very probable that you yourself, everyone who's looking at us, you don't know a person with COVID, and maybe this looks like a remote possibility or like a faraway risk, that you think that maybe it is very unlikely that someone you know or you care about will get COVID, or you yourself will get COVID, because maybe you're looking at the information on the news, and maybe you think this is something that does not correspond with reality. The experience that has been lived by the citizens of countries who have dealt with this problem show that this state of mind of thinking this is not something that could happen to me will lead to a surprise, because you are thinking that this couldn't happen to someone that you know, and suddenly you realize that this has already happened to 2 people you know, to 4 people you know, to 10 people you know, to 30 people you know, and suddenly it has happened to your family and to yourself. We do not mean to scare the population, and we don't want to make them go into panic, but this is the reality. When we're talking about exponential transmission, we use this technical term to refer to the reality that this disease doesn't go from one case to another case to another case. This goes 2 cases, then 4, then 8, then 16, then 32, and then very soon we have tens of thousands of cases that need hospital care. And this could happen so fast that obviously would not allow for the adaptation of the health facilities, of the healthcare system, even though we're doing great work to prepare them. But if this happens too fast, we'll be in very severe difficulties to provide treatment to all of those people who need it. So please, all of the population, do not forget the call we made since a few weeks ago. Stay at home, stay home, stay at home, because that is the only way to decrease the transmission rate and to save lives. When we enter phase 3, which will be in a few days, we have a few days left. When we enter phase 3, we will see a very accelerated rate of transmission of this disease, and then it will be too late. We have very few days to do something about this. All of us, not only those people with the higher risk of complications. All of us have to contribute to this. Please stay at home, abide by these measures. That's what you can do today, right now, to help. Tomorrow we will continue. A la madre.